Hi, this is Dr. Farhan. Please watch this video and I hope you like it.
Start.
Hello, hi everyone. I'm Dr. Farhan, a rheumatology consultant. Today we are going to discuss a case of rheumatoid arthritis, and we will briefly go through the history, examination, investigation, and the treatment plan. And also I will briefly explain the two different types of rheumatoid arthritis, which is seropositive and seronegative. The case we are going to review today is seronegative rheumatoid arthritis. So just to explain you briefly, rheumatoid arthritis is a disease, it's a chronic disease which affects mainly the joints, but it also affects other tissues of the human body. Namely, it can involve skin, lungs, heart, eyes, and the neurological system. And our focus today will be on the seronegative rheumatoid arthritis, in which we do not tend to find any antibodies in the blood. However, it behaves pretty much like the conventional seropositive rheumatoid arthritis in most of the cases. However, again, it is an umbrella term, so seronegative rheumatoid arthritis can later evolve into different other forms of inflammatory arthropathies, namely psoriatic arthritis, reactive arthritis, or axial spondyloarthropathy. It can also evolve into other types of autoimmune conditions, namely connective tissue disorders, including SLE, systemic sclerosis, inflammatory myositis. So we need to be very careful evaluating a case of seronegative inflammatory arthritis, or routinely termed as seronegative rheumatoid arthritis, as this disease later changes its outlook and the phenotype. And we have to emphasize on routine and regular monitoring of these cases, and at serially we need to repeat the immune profile to see any evolution. On the other side, if we talk about the conventional rheumatoid arthritis, which is a seropositive rheumatoid arthritis, where we normally observe presence of specific antibodies in the blood test of these patients, namely rheumatoid factor and anti-CCP, they tend to behave and they tend to present in a very consistent manner among across all the population with all the ethnic backgrounds, and mainly affect, as I said, the MSK side, including symmetrical joint involvement of small joints of the hands, wrists, elbows, knees, ankles, and the toes. It can also affect it can also have extra articular manifestations and can affect other organs, as I've already explained to you, namely heart, lungs, eyes, skin, and the neurological and the nervous system. So let's wait for the patient, and we will have a real-time conversation, and we'll try to record the consultation with the patient's permission. Thank you. So, where we left last time, we reviewed a few weeks ago.
Yes, exactly 5 weeks.
5 weeks ago. And if you don't mind, if you can just summarize what were your presentation, what were the symptoms you were having when I saw you in the GPAU?
So the pain started on the thumbs initially, and then I was started on steroids, tapering dose, 15 milligram and then 10, 5, and then 2.5.
Did it help with your symptoms?
Initially, I would say yes, but after that, like after a week, it was the same. Actually, it got worse. Now I'm having these spots or nodules. I don't know what to say.
Sure.
And the knees are involved as well, hip joints, all my fingers, toes as well, and elbows as well.
Are you just experiencing, sorry to continue on actually, so just to introduce that she is also a doctor, she works here with us, she's a colleague, and she was diagnosed with the seronegative rheumatoid arthritis a few weeks ago when she initially presented, as she explained, with some symptoms of pain and stiffness, mainly affecting the thumb bases and the hip joints. Now she is describing that after having a few weeks of steroids, there was no improvement. She went to Pakistan for a few weeks, where she required another course of steroids, or you had a steroid injection.
I had 80 milligram of the 520. That helped. I think 2-3 days I was able to go upstairs and downstairs as well on my own. But after that it was the same.
But then symptoms recur, yeah. And you were pregnant at that time when
I
this reviewed.
was, yes. Then I had a miscarriage.
Unfortunately, okay. Do you think that it was because of the joint symptoms, or you were generally not feeling well, or it was the long flight which contributed?
No idea.
Okay. And this was your first miscarriage. Now, looking at you, you think that your symptoms are progressing and they are involving multiple joints, both sides symmetrically. Mainly, is it the toes or hands, or you
For
think
the
everywhere?
past 1 week, or I would say 10 days, it's the knees that's bothering me the most, and the hip joints. I cannot get up from sitting position, or it's hard for me to sit from standing as well. And especially my knees. Yesterday and today, this finger was the most painful. Then my elbows, and I'm worried about this situation. It looks horrible, as you can see. It's brown, red, dark spots. My feet were like
If we can show it
Yeah.
to our audience here. Oh, okay. When we will examine you, probably on the other side of the couch, we can have a closer look. So I can see some
similar
purplish.
spots here as well, here, and they are all tender and hard as well. If you like swipe your finger between the normal muscle and here, it is very hard,
So
very
it's
painful.
Painful nodules underneath the skin, and
the color as well. It's
and a purplish, darkish discoloration. This has all started few days ago, or how long?
I would say from the start of July, first week of July. It started as 3 spots on this feet and then.
Have you had any other symptoms apart from some progression of your
I
joint
had
symptoms?
swelling of my ankles. I have a picture of that as well, and they were like a balloon this big, both of my ankles. But I kept a pillow underneath while I was sleeping, and then it slowly.
Currently, you're
went
off
away.
any treatment, if I'm not wrong. You're not taking any steroids.
I
any
am
NSAIDs.
taking steroids, still 2.5 milligrams.
Still 2.5.
And naproxen, but I don't think naproxen is helping anymore. Like, I need his help.
On a good day, she takes 2.5. On a bad day, on a bad day, 5 milligram prednisone, and along with that naproxen. That's it.
Okay.
With BBI.
Fine. Any other symptoms in terms of like any ulcers in your mouth, any problem with your eyes, like you're experiencing
No, I
red,
feel
sore
like
eyes?
crying after every 3 to 4 minutes. That's probably
That's
because of steroids or
steroids.
something.
Pain, okay.
Uh,
But you have not experienced any problem with your eyes when you're experiencing that some light is hurting your skin, like photosensitivity or anything, and you were not experiencing any excessive hair loss or any rash on your cheeks?
Hair loss, yes. I had to cut my hair while I was in Pakistan because I was having
Lot of
hair fall, a lot of.
Is it excessive to your normal self? And are you losing in bunches like when you?
No, not in bunches, but yes, excessive.
And it's not leaving any scar or
No.
bald patches.
No.
Yeah, okay. You never suffer from, or no one in your family suffer from psoriasis, skin
No,
psoriasis.
no.
It's a condition where you develop some silver skin patches. And no problem with your bowels. You don't have any issues with.
I've had issue of constipation, but since I remember, like since childhood, I was having this
But
constipation
no-
on and off. But
No cramps, no bleeding from the back passage with the stools.
I had occasional bleeding as well, PR bleed, but that's again, I thought it's because of hemorrhoids. Nothing major. It's not
It's
something
not,
new.
not like colitis, like inflammation or so in like inflammation in the intestines. You get like crampy abdomen whenever you eat, and then you constantly lose some blood on and off, have diarrhea. Okay. In your family, just remind me, no one suffers from rheumatoid arthritis or any other autoimmune conditions. You don't smoke or drink. All right. Okay. So it looks like, as I already explained to you, that this is a condition called seronegative inflammatory arthritis, which we are still not sure which type it will evolve into in future, because seronegative rheumatoid arthritis is an umbrella term. Where
Eight to
there are,
9 things.
yeah, there are a lot of differentials for this. I've already explained in my intro video about it. If I will explain you again, it can be a part of different type of arthropathies like psoriatic arthritis, reactive arthritis, or axial-spondyloarthropathy. It can be a part of different syndromes associated with connective tissue disorders like systemic lupus erythematosus, systemic sclerosis, inflammatory myositis, and at times it is idiopathic. We don't know the cause of it. In your case, with history of miscarriage, which was spontaneous, we have, I think, already requested some blood tests, but I will definitely like to rule out a condition called antiphospholipid antibody syndrome, which can be associated with all sort of connective tissue disorders. Now, is it okay if I can quickly examine you and then we'll come back and have a look at the investigation and explain you?
And this is the
We are recording this video with your consent, and if you have any objections, you can let us know and we can remove it from our channel on YouTube. Right. Our focus today on the joint examination in a case of rheumatoid arthritis. So, as I said, it normally affects the small joints of hands, toes, and then it can also affect some large joints, including wrists, elbows, and knees. So, in the small joints of the hands, it tends to affect symmetrically all the small joints except the distal row, which is distal interphalangeal joints. However, in the case of seronegative rheumatoid arthritis, you can see the distribution, which is asymmetrical and can also affect and involve the DIPJs. In this case, currently, I cannot see any obvious swelling or signs of active synovitis in any of the knuckle joints. We'll do an MCP squeeze test. I'll just try to gently squeeze. Let me know if it hurts. Any pain? Both sides? Okay, so MCP squeeze test is positive. Make a fist. She's struggling to make a fist, and can I just try to gently rotate your wrist? Any pain? Okay, so wrist. Right wrist is normal. Good range of movement. No pain?
face.
Mild tenderness noted on the left wrist. However, again, I cannot appreciate any obvious swelling or signs of active synovitis, including any erythema or increase in temperature. Bend your elbows. One other feature which is common in seronegative inflammatory arthropathies is the presence of enthesopathy or tendinitis, which can manifest in the form of medial or lateral epicondylitis around the elbow joints. You feel tender there? Where, which side? Right?
This one.
This one? So lateral, mild lateral epicondylitis. Here again?
Yeah.
And this side?
No.
Okay, so again, bilateral lateral epicondylitis is noted. How about the shoulders? Can you lift the arm? No pain, no pain? Can you do this? Now, from downwards. So we're trying to, from downwards, trying to
If
set
the elbows, I have pain in the elbows,
In the elbows.
not in the shoulder.
And okay, keep it this way. So with that, bend down, from downwards. Now try to lift off slowly. Any pain around the shoulders? So we're looking for any signs of subclinical synovitis, subacromial bursitis. No. Okay, so no shoulder impingement, no signs of bursitis around the shoulder joints. I'll have a quick look at the dose. Before that, I just want to show there are some erythematous, raised erythematous tender looking lesions on the dorsum of both feet, more worse on the left side compared to the right side. Are they painful to touch?
Yeah. Yes.
It's blanchable. As you can see, when I press, the erythema is disappearing. However, it is tender to touch here.
And this brown discoloration was well on both the feet.
This side?
Yes.
Okay. Is it new or it was there?
This is new.
This is
So
new.
this is
Okay.
This
This one.
is new. This is new at the back as well.
Any pain at the heels?
Very painful for the past, I would say, 5 or 6 days. From 18th of July to week.
If I press, does it hurt? Yeah, it hurts. So this is again a sign of Achilles tendinopathy, one of the manifestations of a seronegative spectrum disorders. The patient tends to feel heel pain because of involvement of Achilles tendon and the site of Achilles tendon insertion on the heel bone called anticipathy or enthesitis. Is it okay if you can bend the knees, or yeah, if I can have a look. If it's a stoner, can we see the other side?
This is something new.
This is something new. Okay.
This is new as well.
Fine.
It's tender here.
But if you can straighten it, bend, now bend, straighten it again. So you can see there is a restricted flexion up. Can you do it again? So she cannot bend more than 30 degrees on the right side. Again the same. Approximately same. She cannot bend more than 30 to 40 degrees both sides at the knee joint. And this restricted flexion is related to tenderness mainly and mild swelling around both the knee joints.
Yeah.
How about the hip joints? Can you bend? Just bend the knee and then try to bend. So we're assessing the flexion, extension, then external rotation, painful, internal rotation, painful. Again I can see the restricted flexion more than the internal and external rotation both sides. So we'll assess for you any evidence of trochanteric bursitis. Is it okay if I press the sides of the hips? Any pain there?
Yeah.
So she's having some mild tenderness around the site of this greater trochanteric bursa, which is again part of the manifestation of the seronegative rheumatoid arthritis. Right, so we'll do a quick systemic examination. Sorry, just hold for it. Do we have the stethoscope? So we'll just do a quick systemic examination. Deep breath in and out. One more time. Okay, I'm just going to listen to your heart, so breathe normally. No pain in your tummy?
No.
Okay, that's fine. So you can come and we'll discuss about the management and your investigations, okay? Start about your investigations. So we initially tested you for the common immune profile that we normally test for with any patients of joint symptoms, includes rheumatoid factor, anti-CCP, and ANA profile, which all came back normal. So we then investigated you for an extended immune profile testing, which includes anchor profile and complement levels, the immunoglobulin levels, and the antiphospholipid antibody screen that I explained to you already. Reassuringly, your ANA is negative. Your anti-CCP is normal. Complement levels are on the higher side, which is reassuring. Myeloma screen is again pretty much normal with slightly raised IgM, which is not significant in your case. Anchor profile is negative. Rheumatoid factor and ANA was tested previously, it was also normal. So I'll just check the final test, which was the anti-cardiolipin antibodies. So there are 3 sets of antibodies, which we normally do. One is anti-cardiolipin antibody. So IgM and IgG both are normal. Beta-2 glycoprotein is also completely normal. Third one is the lupus anticoagulant. ABTT ratio is normal. It's slightly actually on the lower side, it's not D range. Okay, we have not had the lupus anticoagulant levels, which we can test again. But given that there are the rest of the two antibodies are normal, this is less likely the condition we suspected. And serum urate levels are also normal. Let's see where is your inflammatory marker. So your CRP last tested in June, it was raised.
21 and followed up at
Yeah, it's raised inflammatory markers with your symptoms of inflammatory sounding polyarthritis/polyarthralgia. To me, it is a convincing evidence, looking at your joints, that it is a condition called seronegative rheumatoid arthritis, right? And you are not responding. Are you okay? No, that's fine. Do you need some water or something? Mobile, at least mobile and mobilizing without the pain is the target, right? And keep your joints under control without any inflammation so that you can perform your routine activities is our main target as a rheumatologist. So you will stay with us in the loop and you will receive regular appointments, and I would strongly suggest you to attend all those appointments so that you've been followed up by the rheumatology team in case if your symptoms evolve into different things, we then can at least get a routine checkup from our side, right? In terms of starting the treatment, because you are young and you are planning to conceive, I think the best option will be to give you a safer agent, which is safe even if you become pregnant without knowing yourself, right? Two therapies, two tablets work normally very safely in this situation. One is hydroxychloroquine, other is sulfasalazine. So I would suggest personally, given your condition is slightly more aggressive and disease activity is at least moderate, if not severe, hydroxychloroquine is a benign agent. Sulfasalazine will be a better option for you. Are you happy to start this tablet? I can go through briefly the side effects and the monitoring if you are okay. Right? So sulfasalazine is one of the disease-modifying anti-rheumatic drugs, which you need to take it daily. There are different dosing regimes, but we'll try to normally start in a smaller dose and then smaller increments. We'll go towards a stable dose of around, okay, you wait around 2 gram. Daily dose will be the stable dose for you. I'll start you on 500 milligram. You can take it for a week and then increase slowly in terms of in increments of 500 milligram per week until you reach 2 gram, which will take around 4 weeks for you to reach there. That's one thing. With the start of this tablet, as it's an immunosuppressive agent, you can experience some common side effects. Includes you might feel a stomach upset, very lightheaded, headachy, or you might feel some sort of a rash coming out. But it will settle down with once you will be on a stable dose and after a few weeks. Because in your case, we have limited options, so I would rather give you a longer trial of this tablet before saying that this tablet doesn't work or you're experiencing, if you do not experience serious side effects, which includes your bone marrow suppression to a limit where we have to change your medications, right? And to prevent that happening, we will monitor your blood test. The initial monitoring regime is fortnightly for the first 6 weeks. I'll give you some blood forms. You can take it to the GP or you can come to the hospital laboratory here and get these tests done at regular intervals. We'll keep an eye on those blood results. If they remain stable, we can loosen up your blood monitoring to a monthly regime, and then after a few months, if they remain stable, we can say you can have it 3 monthly. That's fine. It can affect sometime the bone marrow, so that's why we need to be careful. It can also affect your liver sometime, so we need to monitor your liver function test and the kidney function test alongside your blood count. Right? If you experience any other side effects, you need to report to our rheumatology team. If you develop any signs of infection like fever, sore throat, or urinary tract infection, you ideally pause the tablet and then contact the rheumatology team until you have your course of antibiotics and your infection is clear. tend not to start this tablet for a few days once you recover from the infection. That's pretty much it for the DMARDs for the moment. We have other agents. Don't think that this is the only tablet we have. If you do not tolerate it, or if it's not working for you, feel free to let us know in your next appointment. I'll arrange another appointment with our specialist nurse here in 8 weeks' time to review and monitor your bloods. If they remain stable, we will then do a shared care agreement with your GP, who will continuously prescribe you as a regular in your regular prescription. If you need help of physiotherapist or you need help of occupational therapist, again let us know. Key thing with inflammatory arthropathies is to keep yourself mobile and keep doing the gentle exercises as much as you can do to help defreeze your joints. Right? If you need a formal help from our occupational therapist at any stage, again please feel free to let us know. Any other questions or concerns you can ask?
For how long do I need to take this up? For 6 months, year, or lifelong?
So it's a good question. With rheumatoid arthritis, as I explained you already, it's a condition which we cannot cure, right? In seronegative rheumatoid, however, it differs from the seropositive rheumatoid in a sense that I've seen cases that they resolve spontaneously after a few months or a few years. So in your case, we are realistically looking at least 12 months to an 18 months trial of this tablet. And if you remain symptom free and you do not require any steroids during these next 12 or 18 months, no other flare-ups happening in these next 1.5 year time, then we can think of reducing dose of sulfasalazine and slowly trying to wean it off and stop it and to see how things then shape up. So realistically, at least you're looking for around another year or 1.5 years on this tablet. Again, it's a safe in pregnancy, but I'll tell you, if you conceive, it's better you let us know as soon as possible so that we can make arrangements within our department and also liaise with the gynecological team. Disease activity should be better controlled, which will improve chances of your being pregnant. It will improve your fertility, and poor disease control will increase not only the risk of abortions, but also decreases the risk or the chances of being pregnant. It will decrease your fertility as well. So it's favorable for you to take a medication which helps controlling your disease at this stage and then become pregnant once the disease is under control. Yeah? Any other questions?
No.
Abby? Okay.
I'll be working in a hospital, so I have to see like what kind of patients. Being on immunosuppressive, won't it affect my immunity or the risk
Well,
of
good question.
catching infection?
So, are you working? Which units are you going to work?
So in IMP there are all kind of rotations. So
3 rotations you have: geriatrics, endo, and gastro, and GIM obviously the on-calls are everywhere, you know.
With the sulfasalazine, I don't see any contraindication because it's a milder immunosuppressive agent. But in case if your symptoms remain persistent or not very well controlled on sulfasalazine, and we had to increase the treatment to a specific targeted treatment like biological therapy, then you can rediscuss with us, and we will see how we can help you in your placements. Okay. Yeah. Thank you. Just one more thing, one favor, because you know how to speak Urdu, and this video is for our audience in Pakistan. If you can just summarize आप वो symptoms और वो जब आपको ये symptoms start हुए, कितना अर्सा पहले और कहाँ से start हुए और ये कैसे आपको सारा symptoms आपको शुरू हुए, वहाँ से फिर आप हमें 2 मिनट में बता दें तो बहुत.
to be exact, 1.5 महीने पहले मेरे लेफ्ट एंकल से स्टार्ट हुआ था और पेन और स्टिफनेस भी थी, और फिर वो राइट एंकल में भी शिफ्ट हो गया, फिर दोनों रिस्ट बाइलेटरल और बेस ऑफ थंब जो है वो भी इन्वॉल्व हो गए थे. उस वक्त सिर्फ पेन और स्टिफनेस थी, फिर आहिस्ता आहिस्ता करके स्वेलिंग भी हो गई. स्टीरॉइड्स स्टार्ट कर दिए थे 15 मिलीग्राम से टेपरिन डोज, लेकिन पिछले 2 हफ्ते से ऑलमोस्ट 10-15 डेज से रेड कलर के नोड्यूल्स स्पॉट से बन गए जो कि टेंडर हैं, और नी जॉइंट्स इन्वॉल्व हो गए हैं, बाइलेटरल हिप जॉइंट्स इन्वॉल्व है, एल्बोज
हील पे
हील में बहुत पेन है पिछले 5-6 दिनों से। टोज सारी फिंगर्स इन्वॉल्व हो गई हैं और स्टिफनेस, मॉर्निंग स्टिफनेस भी इसमें बहुत ज़्यादा लगती है और ऑन ऑफ स्वेलिंग फील होती है, कभी किस जॉइंट में कभी किस जॉइंट में ज़्यादा पेन होता है।
So migratory है
Migratory.
पूरी आर्थ। Thank you.